So again, thank you for coming tonight, and thank you for filling out the survey. Cassie's very good at encouraging all of us in the clinic to pick topics of interest to us, be they directly in our specialty or in maybe kind of the outside our specialty, special areas of additional interest or research that we have. So this topic, chronic disease and depression, understanding the link. So I've been in Grand Rapids now for 19 years. This is my first and only job out of residency. Married, almost raised all three of our kids here. We have one sitting in the back who is joining us here today. I'm a little bit of one of the last dinosaurs in the clinic. I am the only family doc who still does clinic work, inpatient hospital work, and does deliveries. So when I went into family medicine, that's what I wanted to do, and that's what I've continued to do. Some objectives to go over here. So first of all, we're going to talk about some of the statistics on the prevalence of depression, and in particular, depression as it relates to other chronic diseases. And then we're going to go into this little bit of this chicken and the egg conundrum. Which seems to come first, depression or the other diseases along with it? Near the end, we'll talk about screening for depression in the primary care settings. And then lastly, something that I'm very, very interested in that has to do with the field of positive psychology, and that's called the Gratitude Graffiti Project. Okay? Every slideshow needs to have its obligatory cartoon. When you're trying to find a cartoon that deals with depression, kind of hard to do unless you start looking at Charles Schulz. This is a good example of, there's lots of different things in med school that I learned that had to change and had to grow for the work that I do today. In particular, when we look at the chronic disease model. So chronic diseases, these are all the diseases that we're very, very, very familiar with. So diseases such as arthritis, diabetes, Parkinson's disease, hypertension, COPD, Crohn's disease, and depression. We really need to think of depression as its own chronic long-term disease on the same spectrum as diseases as high blood pressure and heart disease. So chronic diseases are ongoing illnesses or conditions that can be progressive, meaning that they worsen over time. Occasionally they can be static. They just kind of come and they're there. They never really get worse. They certainly don't completely go away. Or they can have exacerbations and remission phases. Asthma is probably a good example of something that can have exacerbations, and then it seems to get better over time. So why in particular is understanding this relationship between depression and chronic diseases so important? Okay? So let's look at number one here. Okay? So if you have depression, especially if you have chronic depression, your average lifespan is 25 years less than someone who has never had depression. To put that in perspective, smoking is 10 years, okay? So we're all very acute to those long-term effects of smoking, but really when you look at depression, it really takes away from our lifespan. This number is kind of old. It's from 2000, so old, but at that point, the estimated cost of depression is $83 billion. And here's the other part of it. 2/3 of that cost being lost workplace productivity. So you think about the treatment, the hospitalization, the medication costs, the clinic visit costs. But actually 2/3 of that cost has to do with workplace productivity. Okay? And that's in part because depression often starts very early. If, for example, you develop high blood pressure in your 30s or your 40s, your symptoms related to that may not show up for another 20 or 30 years. If you develop depression in your 30s and 40s, your symptoms are there right now, affecting you at work, affecting you in your home life. Depression also tends to strike people in the midst of what we would consider these most productive years. So in your educational years, as you're getting married, raising families, as you're working, okay? So that is why there is such that high cost in years of life and as it relates to the workplace, okay? Now we're going to get a little bit more into this tie-in with depression and other chronic diseases, okay? So as I was getting ready for this talk, I went through just my regular clinic weeks a little bit and just kept track. And if I took out of my schedule OB patients, so pregnant patients, and children in for their well child visits, and then I also took out anybody under the age of 15. And I went through a couple different weeks. In my schedule, it was about 35% of the patients that I saw had the diagnosis of depression or anxiety. And you can see where that kind of fits with this slide. So oftentimes you will hear the lifetime risk of depression quoted at about 18 to 20%. Okay? So if you just take the general population that does not have any other chronic disease with it, that's about 10%. Okay? And you can look at that all the way up to if you have a stroke, it is 60%. Okay? So that is a staggering amount. As we talk more later about this interplay between depression and chronic disease, you'll realize why that number tends to be so high, and also why there is such a high degree of correlation with other chronic diseases. So why is this correlation so high? Okay? It's the chicken and the egg conundrum. Do the chronic diseases cause depression, or is there something with depression that causes chronic disease? And with either of those situations, if that is so, why does that tend to be? Another way to look at this is it behavioral or is it biologic? Is it within our physiology that this happens? Okay? So, in part, is it what we actively do or don't do that leads to more disease? Or is it something way more complicated? Okay? Let's talk first about the behavior piece. Okay? Many years ago, early in my practice, I went to a talk by Dr. Reed Sulik. At that point in time, he was the president of the Minnesota Psychiatric Association. And he did one of the best explanations I've ever heard on how depression looks to other people. So when he talked about the symptoms of depression that are seen, he talked about depression being a disease of mood, and that makes sense. It is this sadness, this overwhelming sadness that people have. Equally important, it's a disease of energy, okay? You don't sleep, or you sleep all the time. You don't have the same motivation that you did beforehand. Also a disease of our physiology. It affects pain. It can affect our intestinal tract. It can affect our muscles. It can affect how fast we can run. It affects how well we recover from seemingly minor illnesses. And it's also a disease of perception. One of the other key features with depression is that we tend to have a chronic negative outlook. Are things going to get better? You know, why do these bad things happen to me? And we tend to take on more self-blame. That'll lead to some of the increased behaviors that we will see related to depression that can bring on other chronic diseases, okay? So, yes, there are behaviors that are more common in depression that can lead to these other illnesses or in general are associated with poorer outcomes. This has been the predominant mode of thinking for centuries and centuries and centuries. So on here, again, going through some of the things that we will see more frequently with depression that are primarily within that energy-related field. So certainly sleep disturbances. And again, this can be insomnia. I can't sleep, I can't stay asleep, I have poor quality sleep, or I sleep all the time. As that changes things in our body, it causes changes in our autonomic nervous system. Think of autonomic nervous system as like your automatic nervous system, things you don't even have to think about that occur. And this leads to higher rates of diabetes, obesity, high blood pressure, and metabolic syndrome. Metabolic syndrome is a combination of obesity, higher risk of diabetes or problems with insulin metabolism, and problems with cholesterol. Lack of physical activity. You don't have that motivation to get up and move as you did before. And again, that can cause many of those same illnesses to occur. Individuals with depression may have a higher risk of smoking, alcohol use, and substance use. Those are direct toxins that they're putting into their body, and those direct toxins lead to other diseases. For example, individuals who smoke have a much higher risk of COPD or emphysema, higher risk of certain cancers that are associated with those toxins too. And lastly, adherence to treatment. You know, kind of the, am I worth it? Am I worth doing all these different treatments to help keep myself well? It can be overwhelming to be diagnosed with a chronic illness. You know, I often think if I diagnose you with diabetes today, that may mean I am starting you on a medication. I'm telling you to change how you eat. I'm telling you to exercise each day. I need you to change how often you check your feet for infections. You need to go get your eyes checked. You need to poke your finger several times a day and check your blood sugars. And also because you have diabetes, you need to take aspirin. You need to take these other medicines too. Very overwhelming. So the adherence to all those different changes that somebody else is asking you to make when you may not feel that you yourself is worth it can be quite daunting. Okay? Now let's switch it around a little bit. Okay? Let's talk about the biological link, or you can think of this as a physiologic link. So again, these are things that are occurring within your body that you're not even aware of. So there are certain biochemical and hormonal changes that are caused by depression that can actually cause some of these chronic diseases. There's also some biochemical changes that occur with chronic diseases that can cause depression. So the study of this phenomenon is called psychoneuroimmunology. Say that 10 times fast. Or even better, okay, I think this is the more complete name, psychoneuroendocrine immunology, which I can almost say, okay, which has nothing to do with criminology. All right, let's break that down a little bit, okay? So the psych part, that's the thinking, that's the thoughts, okay? Neuro, you have both nerves, think of them like electrical wires, and neurotransmitters. Neurotransmitters take information from one nerve to another, okay? So our nerves, they aren't just all spliced together. They have little spaces in between. You have to have something that'll communicate between those little spaces. That's the neurotransmitters, okay? Endocrine system, that's when you think about hormones in your body. So these are the hormones secreting glands, and hormones are chemical messengers in and of themselves. And immunology, okay, that's our immune system, okay? That is how our body responds to invaders. This can be external invaders. So when you think about infections, it could also be internal invaders. So when you think about cancer and tumor formation. Okay, all right. So when you go to med school, you have to learn really, really busy charts like this, okay? Okay. I have some nurse colleagues in the office here, and I said they're going to have some bad flashbacks looking at that, okay? And then after you memorize that, okay, you memorize the next slide, okay? All right, so I'm going to give you a little piece of this, okay, called the hypothalamic pituitary adrenal axis, okay? So in your brain, you have the hypothalamus and the pituitary. A signal goes from the hypothalamus to the pituitary to your adrenal glands. Adrenal glands sit on top of your kidneys, okay? So one communicates with the next, communicates to the next, and makes different end products, different chemical messengers. As your adrenal glands release those chemical messengers, it's supposed to go back to these different areas of your brain and say, mission accomplished, you can take a break, don't keep sending that same signal over and over again. With depression and with certain chronic diseases, this pathway gets disrupted. That's where we get that tie-in, okay? So we're going to look at catecholamines. Catecholamines are one of the chemical messengers, one of the neurotransmitters that gets released by the adrenal glands. So catecholamines, adrenaline is a catecholamine. So think about that adrenaline release, that's that fight or flight. Most of the times it's appropriate to the situation, okay? There are certain times when you want your blood sugar to go up. You need more energy and you need it right now. You need a higher heart rate, you need a respiratory rate that's increased, you need to get more oxygen to your muscles so that you can run away from the big scary bear, okay? It also heightens your memory, both your memory of the event itself and past similar memories. with the past similar memories so that you can recall those and you can remember, you know, here's what I did last time this big scary event occurred. Here's how I can get away from that, okay? Your blood pressure goes up, and it also stimulates your intestinal tract. So anything in your intestinal tract that you don't need that's slowing you down, your body wants to get rid of at that time. That's how it's supposed to work, okay? Now, here's when it gets turned on and stays on inappropriately, okay? And you can start kind of anywhere on this slide and take it through different occurrences. Okay, we're gonna use the big scary bear, okay? So here's the big scary bear that causes you to have that adrenaline release and release those catecholamines. We talked about all those different things that happen. Your heart rate goes up, your respiratory rate goes up, your blood pressure goes up, you get nauseous because of the intestinal tract stimulation, and then those symptoms make you feel anxious, okay? And then you feel more anxious, that stimulates that negative memory, and it keeps going on and on and on, okay? So we talked about some of those physical symptoms related with some of the physiology changes. One of those was it increases your blood sugar. Over time, as that blood sugar continues to be increased, increases your risk of diabetes. If you develop diabetes, that also affects feedback to those catecholamines. So you have this falsely elevated level of catecholamines and adrenaline all the time in your body. So let's go back to this slide here, okay? Catecholamines are elevated all the time, inappropriately. It tells your hypothalamus and your pituitary not to work so hard. There's other important things that your hypothalamus and your pituitary are supposed to be doing and sending out signals. So they are getting the wrong signal that they don't need to do that work anymore. That causes increased depression symptoms because maybe your thyroid isn't working quite as well. More prone to other illnesses, more prone to infections because the other things that your adrenal glands are supposed to be doing don't get stimulated. Okay. One of the other hormones that you saw that's released by the adrenal glands is cortisol. Okay. Cortisol is a very potent anti-inflammatory in our bodies. Okay. Some of the things that it does do that can be a little bit negative though are it also increases your blood sugar, causes weight gain, suppresses your immune system, causes muscle weakness, osteoporosis, and poor skin healing. With that being said, there are definitely times when our body needs more cortisol, especially if we're looking at initially fighting infections. So again, we're going to look at the slide here. Okay, let's take somebody who has depression and anxiety. We talked about how that affects our energy levels, tends to lead to insomnia and sleep deprivation. As you get more insomnia and sleep deprivation, our cortisol levels in our body start to rise. As we go to sleep, our hypothalamus and our pituitary tell our adrenal glands, don't make so much cortisol. We don't need it. Therefore, if you're spending that much more time awake, your body still thinks it's supposed to make more and more cortisol. So again, that leads to weight gain, higher blood sugars, that increased risk of diabetes. Now let's throw in here too, as you gain weight, you're more likely to develop sleep apnea or periods of time during the night when you stop breathing, okay? That certainly leads to more anxiety, and if you're not sleeping well at night, more of the sleep deprivation. So you can see where all these different factors tie in together. All right, so now we talked about these different things and how they feed back and can disrupt how the brain is supposed to send out the signals. So now let's look at the question, okay? So what happens if you have a disease that affects brain tissue? Remember the slide that I showed at the beginning, that if you have a stroke, you have a 60% chance of developing depression after your stroke, okay? So if you have a direct injury to your brain, and these are all conditions that cause direct injury to your brain, is that signal initially from your hypothalamus and your pituitary even able to occur? Were those areas of your brain that got injured by your stroke. We talked about the neurons, the neurotransmitters that are released by them. Are those initial neurons able to work? Can they release the neurotransmitters? Can that nerve on the other end that's supposed to pick up that signal, is that a healthy area? So you can see where there can be several areas of dysfunction in there. And that's why these diseases in particular, the people who have these are so prone to developing depression along with it. Okay. Now we talked about some of the things with the endocrine system. Now we're going to move on a little bit to immunology. Okay. If you thought the endocrine system was complex, immunology is way more complex. I shudder to think the amount more known about immunology now than 20 years ago, back when I was in med school. There are dozens and dozens of terms I never had to learn. I never had to memorize. This area is just exploding, okay? So again, young people in the back, if you want future jobs in medicine and research, there's your area. Okay, so many of us have heard about the effects of depression on serotonin in our body, both serotonin production, how well we break it down, how well the different areas in our body and brain that have receptors for serotonin react. Okay, so depression is associated with changes in serotonin production and metabolism. Okay, number 2, white blood cells. White blood cells have one of the key roles in how our immune system works. Okay, they respond to infections. They monitor for infections. They look for evidence of past infections. They help us to prevent new infections from occurring. And they also do surveillance for development of cancer or tumor cells in our body. Okay? So somebody many, many years ago realized, white blood cells have serotonin receptors on them. Why would that be? Why would something in your immune system have something that we primarily think of as a mood chemical within it? This is where, again, a lot of this new research is occurring at this point in time. So we're going to talk about one particular type of white blood cell. Okay, these are called natural killer cells, and I didn't make up this name. This is the actual name for it. Okay, so they are one of our body's first line of defense here. If you get something infection-wise in your body, they respond first through several different mechanisms of action, which we'll talk about here shortly. They are also involved in tumor surveillance. So they are going through our body looking at, okay, normal cell, normal cell, normal cell, up, defective cell over here. They want to try to get rid of it. Natural killer cells have serotonin receptors on them. So they've been able to say that if you have disruption of the natural killer cells, obviously that's going to affect how well our immune system works. So NK is our natural killer cells, okay? And these are 3 different functions of the natural killer cells. So if a bacteria gets into our body, one of the jobs of the natural killer cells is to send out, the best way to think of it is granules. It's like it's shooting BBs at the bacteria in your body. It doesn't stop to be able to tell what type of bacteria it is. It doesn't care if it's a staph infection. It doesn't care if it's strep throat. It just says it's a bacterial infection, shoots out the BBs to kill it. Another one of its functions is it can use these receptors. Think of them like little feelers, okay, or almost little keys on the surface, and it looks for other little sockets in which those keys fit, okay? It typically does that when one of our own body cells gets infected with a virus. So if we get the flu virus, we get hepatitis virus, it looks for these markers, binds to it, and then our own body cells that are infected can no longer work. Viruses rely on our DNA in our body to replicate. So if our cell isn't working, that virus can no longer replicate itself. A third thing that natural killer cells do is it makes cytokines. Now, cytokines are chemical messengers from one type of white blood cell to another type of white blood cell. So these natural killer cells tell these other types of cells that they have work to do. So the DC stands for dendritic cells. Okay? Dendritic cells communicate with other cells with our immune system. And then the T stands for T cells, or certain cells within our immune system that have memory. So when you get a vaccine and your body starts to make different antibodies, so then when it comes in contact with that virus or that illness later, it says, we've seen it before, we can respond to it. As I said, these natural killer cells have serotonin receptors on the surface of it. So if there is a dysfunction in how much serotonin and how often those cells see serotonin, you can see then where you'd be more likely to get different illnesses, bacterial illnesses, viral illnesses, or even more concerning, this is our body's first line against internal tumor surveillance. If you get a tumor cell in your body, can your body initially kill it off? Yes, some of the time, most of the time. It's the natural killer cells that try to do that, okay? So if you have something where your first line of defense isn't working very well, that gets to be where there's that tie-in between depression and cancers, depression and increased likelihood of getting sick. So now we're going to move on here a little bit. We're going to talk about depression screening. Pretty much anybody who's been into the clinic for any reason in the past several years has likely completed some type of depression screen, okay? As sophisticated as medicine is, depression screening is still primarily done with a questionnaire, okay? If you go in and you want to have colon cancer screening done, you get asked questions, but then you go have a test. You go have a colonoscopy or you have a DNA screen done. Still these days with depression, it's still question and answers on there, and can be done at multiple points of entry into the healthcare system. So it can be at the clinic, the emergency department, when you get admitted to the hospital, in the day surgery unit. More and more insurance companies and employers are screening for depression. If you go back to the $83 billion slide, 2/3 of that cost being lost workplace production. So that's really where employers are interested and becoming more interested in how well their employees are doing in terms of their mental health. Okay? So a couple of the most common screens done. There's one called the PHQ-2, the Patient Health Questionnaire. These two questions here, little interest and pleasure in doing things. That's that mood part of depression that we talked about earlier. Feeling down, depressed, hopeless, that's that perception piece that we talked about. This has been used over and over again. It's been used in multiple different settings, multiple different languages, 18 years and older age group. It's been tested, it's been validated that, that those two questions will pick up most individuals that have depression. So the 97% sensitivity means if you take 100 people with depression, 97 of them, if you use 3 or greater as a cutoff, will be picked up by that screen. The 67% specificity means you might score a 3 or greater on there, but it doesn't necessarily mean that you're depressed. However, if somebody does score a 3 or greater, then we should look at doing more questions. Okay? This is the PHQ-9. The first 2 questions of it are the same as the PHQ-2, and it goes through that many more questions. Okay? Also, in clinic, I've probably found to be some of the most helpful is this last part. If somebody answered any of these questions, how difficult has this made it for people to take care of things at home, at work, or get along with other people? That really shows how well or not well people are coping and dealing with their depression symptoms. If we look at this, okay, the PHQ-9 is about 88% sensitive and 88% specific. So if you score a 10 or greater, 88% of those people really do have depression. It can also be used to grade severity of symptoms, because you can have people repeat this over and over again. When you see them back in follow-up, are their symptoms better? Are their symptoms worse? PHQ-9 has really only been in clinical practice for probably not even 10 years. Not even 10 years, I think. Beforehand, we would have somebody come in, we'd start to treat their depression, they'd come back in. How do you feel? I feel better. Sounds good. Send them on their way, okay? With PHQ-9 use over years, it's been shown that people have better outcomes if we treat them to the point of remission, okay? So less than 10, try to keep that score less than 10 over time. It also helps us determining, should we have somebody come off medicines? Should we look at different treatment options? Just a little bit on treatment here, okay? So I put this together with multiple different pictures. Okay. Number one, not a single treatment is right for all people. Secondly, most people do best with multiple different types of treatment, okay? Be that exercise, companionship and physical touch, adequate sleep, okay, can't get that through people enough, meditation, relaxation, sunshine, okay? We realize that very much with where we live here. Proper nutrition, friendship and laughter, psychotherapy, counseling, and medications are all part of that. So now we're going to move on to what I really wanted to talk about. So I talked at the beginning about being able to do these talks for kind of our pet areas of interest. One of my pet areas of interest is what's called positive psychology. Most of it, what we've been talking about today, is negative psychology, depression and anxiety symptoms. Where a lot of the studies have been since the 1930s on have been around negative psychology. If you take depression and compare it to other chronic diseases and put it within that chronic disease model, not only does that mean it tends to be long-term, if you back up beforehand, you should be able to identify risk factors for depression. You should be able to identify triggers for it, and you should be able to look at, is there potentially a role for prevention? If you take what is most clearly one of the most disabling diseases, not only in the United States, but globally, and you could do something to change how often depression occurs, change the severity with which it occurs, delay the onset of it, you have found magic. As I started to think about this was actually when my kids were going through the DARE program, way back when they were 5th graders, okay? So the DARE program is drug and alcohol resistance education, and I looked at what they were being taught there, and I looked at that curriculum and I said, these kids really need to learn something different. They need to learn different steps so their anxiety is less, their depression risk is less, how to be good friends with each other. Also a word that we hear a lot about now, how to be more resilient, okay? As I started looking at that, I got into different bits of research and reading. A couple years ago at work, at the encouragement of some people in administration, they said, there's a conference, Minnesota Hospital Association conference, we think you should go to. There's a doctor coming from Duke. He's one of the lead researchers on physician well-being, prevention of physician and healthcare worker burnout, and resiliency. We want you to go to this, and I thought, this is it, this is great. I'm going to go to this conference and I'm going to learn all the big secrets from the big guru there. So I attend this conference, and he starts the conference by showing us beautiful scenery pictures, okay? Think about your very, very best vacation photos ever. And he talked about how nature and beauty helps us with resiliency. I thought, okay. He had us do some different things with with touch, okay? And Kareen, because you're in the front row, okay? So Kareen, I've known all of my years here at work, okay? Okay, can I have you stand up for a second? Okay, all right. So this is what we're gonna do first, okay? We're just gonna look at each other, okay? Typically, especially in the United States, okay, it is very difficult for us to hold eye contact for beyond 3 seconds, okay? You've done pretty well. You shifted your eyes here a little bit, okay? So go home, even with somebody who you've known for forever, and do that, okay? Now we're gonna do one other thing, okay? So when we greet each other, we shake hands, right? Okay? How long do we shake hands? A second or two? Okay. Now, is it okay if I put my hand on your shoulder? Okay, I'm gonna put my hand on her shoulder. For your brain to really connect that somebody has touched you, takes 6 seconds. Within that 6 seconds, your brain starts to release a chemical, okay, that's called the love hormone. Has anybody ever heard of this? Okay, okay, what's the name of the love hormone? Serotonin. Not serotonin.
I said oxytocin.
Oxytocin. It is oxytocin. I was pointing towards the OB nurses over there, okay? Oxytocin is also one of the chemicals that gets released when we have children, when we breastfeed our children, okay? And it's called the love hormone. It also has a calming influence on each other, okay? So you can sit back down, thank you, okay? So at this point, we're looking at pretty pictures. We're staring at other people. We're touching them for 6 seconds. And then he starts to talk about gratitude and Thanksgiving. One of the projects that they started at Duke for healthcare workers is something called 3 Good Things. Okay, anybody ever heard of the 3 Good Things? Okay, my daughter has. Okay, thank you. Okay, and this in particular was supposed to be the Holy Grail. This was supposed to be the key piece. And what this project is for 15 consecutive days. They had people write down 3 things that at the end of their day that went well. Any 3 different things. With each of those 3 things, how did that thing make them feel? Okay. Let's see. So for example, I went to cycling exercise class this morning. One of the songs that they played is a song that I really like, okay? So how did that make me feel? I felt more energized. I would cycle faster. I would sing along with it. And I wasn't really thinking I was exercising because I was singing at that point. And then the third step with this is, what was your role? What did you do to try to make that happen? Well, I had to get up early enough to come to exercise class to do that, okay? There are many, many times and opportunities, and I would say missed opportunities during your day to look at things just like that. So I'm at this conference and they say, do this for 15 days in a row. Write down these 3 things. How did it make you feel? What was your role in making it happen? And at the end of those 15 days, emotionally, you will feel better. And even more than that, not only will you feel better at the end of those 15 days, that effect will last for 6 months. And I thought, I went all the way to this conference and I got robbed, okay? Because it couldn't be this easy, okay? Anything as complex as mental health couldn't be that easy, okay? Now let's stop and think about this for a little bit, okay? When we look at preventing diabetes, what do we tell people? Exercise and eat right, okay? Lose weight, okay? Pretty easy stuff, not a whole lot of rocket science or neurosurgery going on there, okay? So if we put depression in that same category, why shouldn't it be that something else that can be so easily done have such a positive effect? So I did it. I did my 15 days, and lo and behold, by day like 4 or 5, I was going through my day. I was looking for everything good during that day, okay? When you go from some of those different thoughts of, and I wasn't depressed. I was just doing this project. When you go from just kind of through your day to intentionally looking for every good thing, you're going to find those good things through your day. So as I said, by day 4 or 5, I was looking for those good things. By day like 9, 10 or so, I would wake up in the morning, I would see people, I'd be, hi, how are you? Da, da, da. I'm like, oh crap, it's making me feel better. It's making me a nicer person, okay? Okay? It really worked. So, you know, that worked for me, and I could tell people about my experience individually to try to get them to do it as well. As a takeaway from this conference, though, there was many other authors that they mentioned, different online classes, and that kind of became one of my little areas of interest. So along the way, I am listening to a book on tape called The Grateful Life. It had several different stories, different true vignettes of individuals that had made different changes in their life to try to move it to a better track. Most of the stories I actually thought were not that positive, kind of negative. They were people who were in some pretty bad places in their life and made changes and they got better. And I was listening to those same type of stories over and over again through this book. But of course, I was raised, you got to read the whole book. You can't just stop in the middle of it. And lo and behold, in the middle of it, I came across something that's called the Gratitude Graffiti Project. The Gratitude Graffiti Project was the brainchild of 2 women who met in an early childhood class in New Jersey. One of them was a nurse, one of them was a social worker, and they just thought that they should do something to help promote Thanksgiving, the holiday of Thanksgiving. So they came up with the idea of a month-long, purposeful show of appreciation of one's life through public, interactive community art. So they put up posters at different businesses in towns. They had sidewalk chalk available. They had window markers available. And they encouraged businesses, schools, public places in town to have these public displays of art. I listened to that in the book, okay? And then, you know, there's like those 4 evil words that come into your mind. I can do this, okay? So I thought, if I listen to this whole otherwise not very good book and I came across this, I'm like, I can do this. Maybe this is what I was looking for to make that public health impact that I felt when I did my 3 good things, okay? So last year, we started it, handful of places here in town. So the YMCA Active Living Center, some of you may have seen the big tree that got put together from several different areas of the YMCA in Elder Circle that participated with that. Grand Itasca participated, ICC, Grand Rapids High School, Hope Club, the library, Bender Shoe and Sport downtown, and I'm known for getting other places too. So we talked a bit about, you know, if we can take something as debilitating as depression and move that bar a little bit as far as a community is concerned, you would have huge impacts on everybody's health and well-being. It's occurring again this year. So we look at November 1st through Thanksgiving, having as many places as possible through town, through the community, participate in this. And again, it's simple, okay? Again, the beauty is in its simplicity. Many places had posters that kind of look like the other graphic here, and people just wrote on the poster. Vendors had window markers, and they let people on First Friday write on their windows there. It was awesome. It was great. So anyone here who is interested in this, please let me know, let Cassie know. We had posters available for the different businesses last year. We also encourage different places to be as creative as possible. Yeah, anybody who saw the wise tree that they made last year and how they incorporated all the different areas of the why. It was cool. I told Jamie, who was in charge of it, I'm like, you know how to do this. You know how to get your people engaged. So, all right. Thank you.